So, welcome to NUR 203 Pediatric Nursing. You are now one term away from Stone and getting your goals and your dreams as a nurse. I will warn you, this is a very difficult term if you're in those three different courses. Those who came earlier, I explained, I tried to help you with these projects that are due for pediatrics, how to do it, when to hand it in, and how to do it. So that you're not in the end of the term getting all of these projects, all of these everything done, studying for HESI, last exams, MedSurg 2 is crazy, etc. I'm trying to help you. So I will every class tell you what I think you could do to help. And as we go through this orientation PowerPoint, I'll talk more about it. So in class, how do I teach? Well, I teach on a PowerPoint, but I don't read a PowerPoint. You're not going to fall asleep. I don't do that. What I do is I put a PowerPoint up, and that's information for you. I summarize it. That's all I do. I don't read it. I try to explain it in a manner that you understand it. So those PowerPoints are not just me reading and you becoming bored. After each chapter, starting next week, you will be getting a Kahoots after the chapter. And what do Kahoots do? It's something I've worked extremely hard on. And these Kahoots will immediately test you on the concepts that I just went over on that chapter. It's like, okay, which one is it? And then now you know where your weaknesses are if you're listening in class, doing the Kahoots and saying, oh, I didn't know what this word was. I didn't know what this meant. Write them down. After class, you can look them up, or you can relook at these videos, or you can do whatever, go into the book. You could go to all sorts of sites on the internet today. There's so many good sites, but there's some that you got to be careful with. But again, any questions about anything, you're not getting it, let me know. But I've heard from students and I see the differences in test grades by just splitting up those Kahoots made a big difference. It's like you're immediately tested on the information I just did. So think about it. If you come to class and you've already looked at the information, and starting on week 3, you better read before you come in because the quizzes will be on that week's information. And there's 25 questions on it. So when you come to class prepared, you have an understanding. Then I'm going to teach you by putting the PowerPoints up, giving you examples, giving you children that I've had in my past and showing you scenarios that you can say, oh, now I can get it. Now I understand it. Now it makes sense to me. Okay. So I will do that for you. And then the Kahoots is going to reinforce all of those things. So we're going to do PowerPoints and we're going to do Kahoots. Now, if we're like really quick and we get through with all of the information quick in class, I can always do different things. I happen to be very good at dosage calculations. I do not teach the ratio proportion thing. I don't get that. That's putting things up, crossing things off. I personally don't understand it, but I'm going to send it to you all. It's a dosage calculation video. If you have problems, remember there's 10 points on every exam on dosage calc. There should be no points missed on that, okay? I can show you how to do math, do it easy, and again, it's going to make sense to you. Instead of that ratio proportion, I don't understand it. But even if you still do that, the way I explain it, you'll be able to pick out the numbers and how to use them in the best way. Okay, so if anybody needs any math help, please make me an appointment, come see me. I'll send you a video. I'll send you the handouts that go with it. We can meet, and in 30 minutes, I can teach you everything in math and make you not get any more points off. So let's go ahead and start with our first PowerPoint. Now, they're all a little bit different, but they're all basically say the same thing. I think basically what you need to understand is that there's rules that have to be followed. There are ways to turn in homework and how to turn it in. There's ways to do exams and quizzes, and those things we're going to discuss all of them. Can you see that PowerPoint on your screen? I got this new screen thing, and I'm working with it. So hopefully I got it working. I can see in all different corners here. Okay, on my nursing, they should be the same rules as on ground, but I've worked on ground. I know there's a little differences. There shouldn't be, but there are. Okay. So I'm going to tell you what I expect in my program so that you can do the best that you possibly can. Okay. Remember, you need good internet, you need a good battery, or you need your cable, your charging cable when you're coming to class. Don't come to class, your battery dies, you're not around it. It was going to be missing attendance, and you don't want to do that, okay? And we'll go in why. So I am Betty Bogart. I am the professor for this class. I also am the lead pediatric professor. So any problems, concerns with your fellow roommates, your fellow students, classmates, if they have problems and their professors are not taking care of it, you can always come to me. I'll always answer any email, any text, anything that comes to me, okay? So this is my email, bbogart@fortiscollege.edu. And this is my real cell phone. And I put it here. When you use my cell phone, it's better if you text me, tell me what you want. And when you text me, it's because you need information quickly. You can send me messages on Canvas, send me emails. I answer those very quickly, less than a day, sometimes less than 3 minutes. I mean, I'm always looking at those things because I know you students are so busy with so much going on, and sometimes you need answers now. So if you're texting me or messaging me, you want a quick response, and I will give it to you. So that is my cell, 305-951-8055. Now, if I'm not giving you what you need, where is the next place that you go? Well, you're going to go to the Dean of Online Nursing, which is now Joanna Shed. And there is her email there, and you can contact her there, and she will get back to you, okay? Now, communicating. Remember, be professional in everything that you do. We are, and you will become professional nurses, registered professional nurses. So every way that we look, we speak, we need to be professional. Again, and you're talking to me, make sure that you remember that. I mean, I didn't know putting capital letters in text means that you were yelling at me, but I guess don't put capital letters unless you just want to emphasize that one word or something. Now, our class starts at 8 o'clock and it goes up till 10:41 tonight. We're going to be early, okay? I always try to get you out early. Now, I have a question for you. Do you want to get a break or would you rather get out about 25 minutes early? What do you all want?
I personally would rather get out early.
Same.
Get out early.
Yeah.
I mean, I don't mind running through the whole class. Doesn't bother me. If I have to get up and go to the bathroom or something, of course, I'll say, excuse me for a second. Also, if you need to get up and away from your camera in the chat box, just say, went to the bathroom, be right back. The door is knocking, somebody's there, or my kid's running out the door, my dog's running down the street, whatever. Just let me know so I know what's going on behind the scenes. Another thing is, I know you guys are coming from community or wherever and coming to this class, and many of you haven't had a chance to eat. I don't mind if you eat on camera and you drink on camera. Just don't be sloppy, okay? Just be professional as you're eating or drinking. I don't mind it at all. I mean, I've got my iced tea. You can have whatever you want to drink there. Okay, we do have discussion boards in this class, and they start this week. By tomorrow night, midnight, you should have put the initial discussion post in. Be careful. There is a section on nutrition. with infants and children. So, yes, I want to know who you are, why you want to be a nurse, but I want to know about what you think about nutrition
Yeah,
because
I had
I'll
to
tell you
put that
right,
in I had to do mine in the reply box
that's
because I
fine.
got ahead of
I was going to
myself.
say, if you've already handed in, send another one in or put it in the comments, do something. Just show me that you did it. Yes, very good. Thank you for saying that. I always remind students because you're so quick to try to get it done, and it's like you didn't read all the way down. So I don't want anybody to get knocked down because they didn't have that. I also will take about four, maybe students every single discussion question and I will write a comment to elicit more of an understanding or have you think about something about that subject. For instance, this one is about nutrition. And I'm going to say, so how would you, with nutrition, I would ask a question. When should you give whole milk or honey to an infant? Or I'll ask you some question which will make you think, okay? So see if you see those, respond to them as part of what they want these discussions to be. When you do that first post, that's by Wednesday night, and then you've got two posts that are due by Sunday night. That's just basically looking at another person's point of view. Do not copy and paste AI for me. Don't do it. Put it in your own words, please. Yes, you can use AI. I know you will. It's fine. I get it. But don't give me the la 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 language that I'm like, oh my God, I don't speak like that. Please. Thank you. Academic
It makes you
integrity.
sound like a Harvard graduate.
I'm not a Harvard graduate.
Yeah, I don't know.
I'm a Barry University graduate, which actually is a very good school in Miami. So, academic integrity. This is one thing that bothers me. I worked hard to get my nursing license. I was 19 years old and a young kid when I went to school. And, young kids, you're just 19. You don't focus as much as you should, single, no responsibilities, right? Well, I barely passed nursing school. I had a 2.28 GPA, but I never cheated. It was all my work. And if today you go to the hospital, even though I've been gone for a few years, they'll still tell you they know who I am and all the programs that I made for them because nursing means the world to me. I want you to try and do your best work. Don't cheat because when you sit for that NCLEX or when you have a patient coding on you and you don't know, you're going to be upset with yourself. So when you are doing quizzes, make sure don't go off of it. Don't have another device hidden somewhere taking answers. Do your best work. If you're struggling, meet with me, tutor with me. I can get you to pass, but you got to come to me. Okay. Same thing with Professor Pace Gismar. She's very adamant with this. Plagiarism. Make sure when we do this project, and later on I'll tell you the project, make sure again, change the words. Make the words your own, okay? Don't use any of these projects that are on the internet because EA knows all about them. And they've been looking at them and they'll come up in a plagiarism. And you do get plagiarized checked before the assignments comes in. So just do your best work. If you need help or don't know, send it to me before it's due and I can help you. Again, we know we're professionals and we have all these ethical duties to do that and be as a nurse. Now, we talked about those things at sites that can promote cheating or offer all of these projects and stuff. I looked at them. They're not all accurate. It's not all accurate information. That's probably the biggest problem. You want to learn information that's accurate because you're going to end up taking care of patients and children and grandmas and grandpas. And if you don't know the information, you can be dangerous. Nursing is a very hard job. It's a lot to remember and to know. And again, I was talking earlier, you don't know. You start asking questions because you don't have to know everything you've got to know when to ask questions. That's the thing, okay? when you're doing projects again, always make sure you've got your references up there. And please stay off those things, Sudoku, Course Hero, Stuvia, and there's a lot more. And I've looked through them, and just be careful. Don't do it. Do your work. So homework, discussion questions, assignments that are assigned open up on Sunday at midnight. And it closes the following Sunday at 11:59 p.m. Whatever the grade that you earned, you will get. If for some reason you cannot get that assignment done, an NCLEX question, a SIM chart, stuff that gives you some points that's going to really affect you, can affect you negatively, please let me know before you cannot get an assignment in. Okay? Depending on why, I can get you the assignment and not take off 10%. You don't tell me what's going on, it's a 10% deduction. You're going to hear me say this over and over again. Tell me before. Don't tell me after. I can't do anything. It has to be before, okay? After the second week, you cannot turn that assignment in at all for any reason. There's just very extraneous circumstances, like you were in the hospital and ICU and you couldn't. I mean, things like that. But they're very rare that we would ever accept it after a 2 week. Attendance. And I know this is a big thing with all of you. You must be here at 8 p.m. Eastern Time before then. 8:01 is 15 minutes late. Okay? So make sure you stay. Also, if you leave early, it's going to be the same thing. I will take off time for that. We know that when you are in class, you can't be in a car, whether you're sitting in a parking lot, whether you're a passenger, of course not driving. But again, it's all the legality. We don't know you're driving, your safety, other people's safety. So no, we can't have people in cars, okay? Now, you must attend class every single week. Let's say you had to miss a week. Don't ever miss 2 weeks in a row. 2 weeks in a row is an automatic drop from the course, unless you've called me, you've texted me, you've messaged me, you've emailed me and let me know what's going on and why you can't. And then we will work with it. So we don't want to drop anybody, okay? That's part of the attendance. The other part of the attendance is making sure that you enter something in Canvas, 2 things every week. This week will be, you've already done the quizzes and whatnot, but you have a discussion question, and then you go back and do the responses. That's 2 times that you've gone in and documented in Canvas, okay? So it's not only coming to class and being here, it is also making sure you post in Canvas. And I've already talked about, I do if you leave early, if you come in late, yes, the time will be taken. Know that 20% is 2 full classes missed and a little more. And that little more is when you're 1 minute late or leave 2 minutes early. So don't do those things. They add up very, very quickly. You will be notified when you start getting too much. So you will be aware. And that's basically what I just said. You're going to get that at 10 and 15%. And of course, you'll be warned and you'll understand. So how do you succeed in this course? Well, number one, you need to know what's due every week. Every week by Sunday, usually Saturday I do it, I will do an announcement. And in that announcement, I put what is due every week. It's right off the syllabus because that's what I follow, but I put it in one place for you. And it will show you what chapters, what it's about, and then what assignments are due. And that's on the first announcement I put in the week, okay? The second announcement will usually be after class, and you'll probably get yours tonight by 11:30. because I like to get recordings and everything posted as quick as I can after class. Some of you like to look at it right away, some of you don't, but whatever. I get it up quick so that you do have it there, all of your information. You will know what is due. Also know that your syllabus is what we follow. There's going to be one change. I don't know what I'm doing with it yet, but week 10 is Labor Day. It's also supposed to be an exam. The whole week is an exam. So I'm going to figure out what we need to do for that, if we're going to give it that week, or we'll figure something. I'll keep you in touch. But besides that, the syllabus is your guide. I do not send 100 emails or announcements. I don't. The only time I send messages to you is when you really need to know what I'm saying, okay? Something very important. So I know you have 3 classes. I know some of your professors are announcement happy. They send messages and emails and a this and a that, and you're like, oh my God, how many? And you stop reading them because it becomes ridiculous. And I know that. If I send an announcement, you need to look at it, okay? I don't just la, 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 la. No, you've got enough things on your plate. You don't need me doing that too. And I don't have time to send all that stuff to you. You need to talk to me if you need stuff too, okay? So again, to be successful, you need to tell me what's going on. I need to know what's happening. Again, make sure that you have a good internet, that your stuff is plugged in, ready to go. Make sure your homework gets done on time. If not, let me know why. I can work with you. If you need help with exams, I don't take exams well. I've always been like that. I just don't. So to sit down with somebody and just to go hit back and forth concepts, that's the way that I learn. So if you need, I can do one person, or I can do a couple people, or whatever you want. I can do little study sessions, or separate little exam reviews, whatever you need. But
That's really
again,
helpful.
you got
Thank
to
you.
talk to me. You got to tell me. I'm here to get my entire class passed. Last term was the first that I had 3 classes. Everybody was successful. That was amazing. And I took a lot of work to get it there. And the students worked very hard. And that's what makes me happy. That's why I am a professor of nursing. That's why at my age, I'm still teaching, because I like it still. Okay. Day 1, I hope you've all gone in. Most of you have. I've looked at it, and you've done your little quizzes that have to be there. They must be done before you can go into week 1. If you can't enter week 1, you haven't done those pre-things yet. The quiz and syllabus quiz, et cetera, et cetera. So make sure that you do that. Again, starting week 3, when you come in for your quiz, it will be on week 3's information. So you must be on those quizzes, read, look at least the PowerPoint, know a little bit what's going on before you come to class, because you're going to be hit with a quiz, and there are 5 quizzes. It's 5% of your AGA. So it can knock you down. So be careful. If you listen in class, you listen to the cahoots, you should be okay. But coming to class prepared, oh, it just makes that information, makes it really understandable in your brain. If you are in a quiz, or if you are in an exam, and all of a sudden your internet goes down, or all of a sudden your computer turns black. I mean, all of these crazy things has happened to me. Number 1, first thing, you all have cell phones. Text me, send me a message. Hey, this just happened. I can see every stroke on your exam and on your quizzes, everything you've touched and the time. I know everything. So when you tell me that exam, shut off, it was done, and you were only on question 16, let's say, number 1, The exam is never lost. I can always bring you back another day and start you back up where it was, but you've got to tell me immediately. And then I take that time that you sent that message and I look at the timestamps on your exam soft and they match. We'll just continue the exam at another time when your computer or whatever was wrong is fixed. Okay? I don't do per se weekly reviews. What I do is if you need me, holler and I'll get with you. I'll be here early before class. I will stay after class if you need for anything. If it's an exam review, you need a separate review with you alone or with your buddies in them, set up a time with me. Yes, I'll do it with them. But I don't see every Thursday at 8 o'clock, I do this. No, I don't do that. You tell me what you need and I will do it for you. And that's all about tutoring. I know that I've gotten students through that weren't doing well. And after the quizzes, and I start seeing, your week and quiz and exam one, your week, oh, I'm going to be reaching out saying, hey, you're not taking exam two until you see me first. You need to come. We need to talk about it. Let's see what's going on. Your brain needs to start thinking. You have got to stop thinking about memorizing. Memorization is not nursing. It's understanding that why that happened and what I need to look for and what did I do and did it work? Did it fix it? That's what you need to remember, not those definition things. That was before. Now you're going to now have to put all the pieces together. That's what I'm preparing you for. And that's how I'm going to teach you so that you can think better. Now, those of you with Professor Pace Gismar, I do have a YouTube channel. It's Professor Bogart Pediatric Nursing. If you ever want to see my lecture or any lecture, dosage calc, anything, SC reviews, go to YouTube. It's a public channel. You can go in and look at it whenever you want, okay? So KGA, what is it? KGA is unit exams, quizzes, and your HESI. Oh, I've got a great HESI review for you. So you're set for HESI. I do a HESI Q&A the Saturday before the HESIs. I also have HESI Cahoots that really bring in the concepts you need. So you're good with a HESI if you do what I tell you to do. Quizzes, the first one we're going to be doing is going to be on Canvas, right? From quiz 2 to 5, they're all going to be adaptive quizzes through your share path in your computer. It's one of the things that we do. There'll be 25 questions starting week 4. The first quiz is just going to be on Canvas, 10 questions. But from 2 to 5 will be share path. And what they do is they test you on your knowledge and it changes according to your answers and how you're answering. And it actually is a really good quiz. It makes you think about stuff that's going on. All right. So that's what be going on there. The other 20% is that busy work. It's that homework. Now, I do not have sim charts open before their time, which is your case studies. I don't. I will not open them up until they're supposed to be due because, for instance, there's a respiratory sim chart, okay? It's in week 5 because we study cardiac and respiratory. Why would you study respiratory in week 2 when you're talking about infants and toddlers, right? I want you to do the sim chart when they match the course material. It will make more sense. So that one's not open. NCLEX questions. You can do it whenever you want. Just submit them when they're due because you got to make sure again, 2 times every single week, you've got to post something in your Canvas shell. So again, that's one of the things that you would be posting. Discussion questions are also open. You can start doing them. If you want to. The initial. Some students like to get, quote, the busy work done, but you cannot do those case studies or those practice exams because they have to be done with the course. It just makes more sense and it does It's better for you. Trust me, it is better. There is a paper due, which is a project that you can start turning it in tomorrow if you wanted. And I'll go when I get to that section. So 80% is KGA and 20% is all your homework. Now we turn on homework grades and turn them off. And you're saying, well, why? Well, we want you to know what the homework grades do to your overall grade. If your homework is not done, it can negatively affect you. I'm going to give you an example of last term. I had a student who was brilliant on exams and quizzes, and her HESI scored A's on everything. She only did 15% of her homework. She just passed. Why would you do that if you had an A? Anyway, homework affects you, and it could go from a 94, 95 to a 78 point something. That's how it can affect you. And that's only 15%, not the whole 20%. So we turn the homework grades on at week 6. You're going to see NCLEX questions and your sim charts start to show up in the grades, and you could see how they make a difference. I'm going to give you one advice. Don't turn any homework in less than a 78. Don't do it, because in the end, if your KGA is 78 point something and your homework grades, you didn't do that 78, it could put you below, and then you wouldn't be successful. I don't want that for anybody. So make sure your homework, get it in, and do it with a 78 or higher. Also know once it's turned in, you can't return it in. NCLEX questions, you can do them over and over and over again until you get the grade you want. But once you send it, that's it, okay? On week 8, we turn them off again, okay? And you will not get homework grades turned back on until the very end, and that's your final grade in this course. So basically, that's what all of this says here. So exams and quizzes. On exams, you must come in on another device, okay? And you need to have your laptop. When you get your ExamSoft and you have that exemplified downloaded in your computer, make sure you do the practice test. If something happens in the exam that you can't do it right, if you've not done the practice test, there could be a minus 10% deduction on your exam. Don't do it. So please, everybody, I will set them up. They don't come out till the end of week 2. ExamSoft comes up. So when it comes up, please do your practice testing them. It's just simple. It's nothing big. It's just questions about la la la. And it's just showing that you know how to work the device, okay? It's not a knowledge thing. So again, that's going to protect you. Another thing, make sure they're plugged in. Make sure you have the charging cords. I've had the craziest thing. Oh, I left them at work. They're in my husband's car, or it broke, or the dog chewed it, or the kid has it, or make sure your responsibility as a nursing student in an exam or quiz is that you have the proper equipment ready to go. Just like being a nurse, you need to be in your uniform and you need your stethoscope and your pen or whatever, right? You need your equipment. Same thing. Another thing you'll hear me talking about is keeping the whole face on camera. We tend to get tired and start going like this, or we get tired and we start going like that. And again, whole faces have to be on camera. And I will remind you if you don't. Quizzes cannot be made up, and they must be proctored on camera, okay? So again, and there's only one quiz, one attempt. At the end of the term, if one quiz is making you not pass, you can appeal it. And you can get to take that quiz. Let's say you were late, you came in and you couldn't take the quiz, or you had to go to the doctor, or you had a this, or you had a that. If you give me documentation, you can prove that, okay, at the end of the term, if you need it to pass, that means you're like a 77.5. That's or 6. It's the only thing that will get you one quiz. That's about all it will affect your grade. The quizzes or the first one is right through Canvas, and the other one we'll have to go to there when we get there, and that's through the share path. Exams. Again, make sure you do the practice, and make sure that if there's any problems, you let me know right away. You are coming in on a phone, so people come on iPads, making sure you're on camera at all times. You need your ID. No paper is allowed. Get a baggie, get a dry erase marker, put a piece of paper in the baggie. That's good enough. You don't have to get these dry erasable things. I mean, you could be creative, but the baggies are great. Get one of the gallon size and you can write on it and just wipe it off. It's really great. So no papers, all right? You can only take exams one time. Some students say, well, I wasn't feeling well, this and that, and that's why I didn't do well. If you're not feeling well, tell me, and I'll tell you you're not taking the exam now, and we'll schedule it for another time within 1 week. You can't do it every single exam, but if you're sitting there feeling horrible or with a migraine, why would you want to do that? That's the one thing that you can postpone if you have a reason. Tell me before, not after, because it won't work. You can't retake it, okay? Again, if you have accommodations, you get extra time. I need them ASAP. If anybody has them, I sent out a message in the announcement. I need them so I can program your exams to be extra time and your quizzes to be extra times, okay? There are some campuses that students like to take their exams on campus. And I don't have a problem with that at all. But you have to tell me 72 hours prior. So you need to tell me you want to take it on campus, and you need to give me a name of the proctor. And the proctor must send me an email stating, yes, I am proctoring her. And it should be, if possible, at the same time, same day as I'm giving the exam. Okay. Some students just prefer to be at school, or they're already at school because of something else, and it's better to stay there than rushing home. Whatever it is, you've got to tell me 72 hours before. I've already said all that. How many times do you want me to tell me before, not after? And again, communication is going to be the highlight of this whole thing. If you don't talk to me, I don't know. I can't help you. If you're having problems, stop, and then let me know right away. You're HESI. You get one attempt of that. Again, I do a Saturday at 2 o'clock in the afternoon HESI review every single term, and I'm going to go over concepts that I see on the gap analysis, which is a printout of the HESI exam, and it only tells me, let's say, GI intussusception, and that's all I get. I don't know questions. I never see an exam. All I get is a concept. But from that, I can say, well, what would they want to know about that disease? And then I start saying, well, this is what it is. This is how we approach it, and making you think. And I do that on the Saturday before. And of course, you're going to have those 100-question HESIs. And again, I redo them, add things, subtract things every term to try to help you. I have actually quite a few 99.99s on the HESI – if you do what I tell you to do all term. There is a remediation. We know it's that personalized remediation plan. I think that is really good compared to what they used to have. And again, you just need to check 100%, and then it must be done by the Monday of week 12. Homework, again, it's all by the syllabus. I'll tell you in an announcement every week. I will also tell you in class. Like today, I told you, all you have to do is a discussion question. And we're going to be going over chapters 26 through 30 through 30. A lot of different chapters, but I'm going to make it easy for you. I've already gone over late work and NCLEX questions. Again, NCLEX questions, make sure you don't send me that little green square box type thing. I want that 16-page printout. I want the whole big long thing. All right. If the first NCLEX questions, you don't send them in properly, I'm going to give you a 0, but I'll send you a message in the comments saying you didn't submit it properly. If it's the formatting, I will send you an instruction sheet on how to format it. Okay. Another thing, the first set of NCLEX questions, it is not under pediatrics. It's under growth and development, and it's on infants, toddlers, preschoolers, school age, adolescents. It's different. Again, I'm going to have at least 2 students every class that does regular pediatrics or can't find it or don't know how many. There's not enough questions. It is not in pediatrics. It's in growth and development. It's a different subtopic in the NCLEX Saunders questions, okay? And that will be there on the first one. So if you see a 0, don't get upset. I'm not going to take 10% off. You tried to turn something in. It wasn't right. I give you 1 pass
Do
so you
you
can return it.
do you give us like an announcement on where to like what options to click for the NCLEX questions?
It's in the modules.
Okay.
It's in the modules. It's there.
Okay.
Every single NCLEX question, it's what type of things that we want done. I mean, for instance, the first one is all about growth and development. And then the second one is going to be, different things that go on, more cardiac, et cetera, et cetera. So again, any problems with it, let me know. I can always sit down, work with one before class, after class. I can show it to you. It's not a problem. Remember, NCLEX questions don't turn in anything less than a 78. Every NCLEX question is 1% of your grade. Don't do it. Send me, actually 1.25%. So please give me a 78 on all of them. The HESI assignment and practice exams, we know that it's something that's done in week 8 and 10. They're not open early because it's practice for the HESI, okay? Those SimChart case studies, you've got to read them. You can't go to the test at the end because there's questions that are in the scenario in the descriptions that you wouldn't know unless you read it. So again, give me a 78 on those at minimum. And there is a practice sim chart that you can go through and do if you need to. If you need my help again, let me know. Now, we do have one project due. It is 3 different sections. It is 6% of your grade, so it's pretty big, of your homework grade. The first part of it is you've got to figure out a diagnosis that is pediatrics. And you've got to do an assessment on it. For instance, it could be ADHD, could be asthma, could be a cardiac problem, could be, IBS. It could be anything that could affect a child. What I tell you to do, pick something that you want to know about, what your daughter has, your friend's kid has, you had, or you saw somewhere you want to know more about. Make it interesting to you. And I tell you, I want to see diagnoses I've never seen before. I want you all to teach me something. Last term, I did get several, and it was great figuring out new things or new types of this or that that I've never heard of. So again, you must tell me your diagnosis before you start. Okay?
Where do we tell you? When do we tell you?
Whenever you figure it out. This
I,
is not a project due till week 8. Start thinking about it now. This is what I'm telling you. I'm helping you with that busy work before it's going to get there.
do we
So
just email you then?
email me, message me, yes, and I'll tell you yes or no, and I keep a track of it. Now, in your modules on week 8, there's a list of, I don't know how many, a lot of them, diagnoses. It doesn't have to be on there. There's thousands of more diagnoses besides those. If you think you want to do something, it's not on the list, or if it's on the list, let me know and I'll tell you yes or no. I don't want all ADHDs. I don't want all autisms. I don't want all asthmas. I want a little bit of everything. Okay. So if you're the first person to get it, you got it. If you're the fifth, I'm going to tell you to do something different, or maybe I could suggest something similar to you. Okay. So as soon as you know them, do that. So first part, the paper. It's only 250 words, but it must be an APA. That means I want a title page. I want to have references, and it must be an APA format with citations in it. If you don't know what that means, let me know. I can send you information. Purdue OWL is an internet program, a website that's perfect to do your APA. If you all want to go on and get your higher level degrees, this is the only time you're going to be doing studying and book and testing. BSN, MSN, PhD are all papers, PowerPoints, poster boards. It's all now writing an APA. So I can start to help you learn it now if you start early. Do the paper early. Send it to me. I'll correct it for you. I'll send it back to you so that you can see what it should look like. Community is going to have a paper for you. Guess what? You can use the formatting there if you give it to me early enough. Send it to me in the email. I can't do that on week 8 for everybody. I've got 4 classes. It ain't going to happen. Send it to me early. Yes, I can help you with it. Okay. Second part is a downloadable thing in the modules on week 8, and it's the pediatric assessment form. It's like 13 pages long. Most of it's circling, circling, circling. It's no writing. But the most important part is the last couple of pages. I want to know how a child looks at life through the eyes of certain theorists. And I'm going to go into what those theorists are. Is it Erickson? Is it Piaget? Is it Goldberg? Or you'll figure out who they are. I'm going to teach you how to learn those things. And then the third part is, let's say you had a child that you were teaching me about asthma. The third part is teaching. So you could do a PowerPoint, a picture board. You could do a pamphlet. Teach me about asthma, preventative, or how to use an inhaler, or what the medicines are, or teach me something, how to keep away from the things that make you have asthma attacks. A teaching. And I'm talking, this is a PowerPoint, 5 slides. You don't have to go bonkers with it. I don't need 40 slides. No. Quick, distinct, tell me what you want to tell me and put references on it. That's the one thing many students forget. The PowerPoint or the whatever the teaching, references, because that's not you teaching. Somebody, you got that information from somewhere, okay? Again, I'll be going over this almost every week with you. There is a rubric, follow it, okay? And I do grade by the rubric. Again, I've told you, do not go anywhere near those sites to cheat. Yeah, you're going to see a whole bunch of papers there. You're going to see a bunch of stuff. It doesn't mean they're right. That doesn't mean they're correct. And if you try to use them, it's going to come up in the plagiar checker, okay? Don't do it. And that's all I got for you on that one. Any questions? So what do you think the key point of online is? It's about communicating, isn't it? Talk to me. We can help you. Professor Pace Chismar or I, doesn't matter. We're here to help. You have to tell us before. Don't tell us after. And I know that she works just like me because I oriented her. She is somebody who really cares also. Any questions?
Will
I have a
you?
question.
Oh,
Oh,
sorry. You can go ahead.
okay. You had said something about the exam, the last exam. I think it was week 10, I think.
Week
Yeah.
10 is Labor Day week. So, yes, it doesn't affect you, okay? But we usually don't give one thing for if one class didn't do it because let's say Monday is Labor Day and there was a quiz, we don't give it, but this is an exam. So, we might give it to you there and then have the Monday people do it at another time. I'm not sure yet what I'm going to do with it yet. It's
Okay.
something I have to discuss with management, but I'll let you know. I'll let you know plenty in advance. Don't worry. It's already
Okay.
on my agenda to take care of.
Thank you.
Yes, Mia, something else?
With you were mentioning, I don't know if it was HESI or just all exam reviews on Saturday. It too, but I always work on Saturdays.
My
And so I was
exam
wondering if
reviews will be
you said you post them.
all the exam reviews will be
Hmm.
posted,
Okay,
okay?
thank you.
All the professors, okay? Of course, mine will be very soon after it is done. I do my exam reviews on Tuesday. I think it's 4 o'clock, all of them. Tuesdays at 4 o'clock. The HESI one is on Saturday at 2 because it's right before the HESI. And
Okay,
again, it's recorded. You're fine.
perfect.
Another
Thank you.
thing, Mia, you go to my YouTube channel, you'll see last terms and the one before, and they're similar, but not completely. Okay. Because of course I've added stuff in them. Any other questions? All right, let's go ahead and now let's do this week. You know, this, is that you? Insa, did you need me?
I was gonna ask, when you was talking about the week 8 stuff, is there like a little template that you can give us so we can have like a general idea of how you want it?
It's in the modules, it's
Okay.
there, different things. It's a paper, it's a form, and it's a teaching. What I suggest, are you in my class or are you in Sarah's?
I'm in your class.
Hey, when you're doing it, send it to me or talk to me and I'll teach you. I'll show
Okay.
you. I mean,
Thank
it's not a
you.
problem. So this week, chapters 26 through 30. It's a lot of stuff, but it's a lot of things that's going to be repeated through the course. But there's certain key things in there that you'll hear as I keep going. So let's go ahead. Week 1. Can you see that? All right. So, healthcare for children. You know, children are a vulnerable population, okay? That means that, they have specific things that can happen to them, and unlike an elderly or just an adult, right? So, the government has done these healthy people things, and I had no clue what they were. And I went back for my BSN in 2009. I went back to do my BSN. I had an associate degree for over 30 years. And I decided that, yeah, I want to end up retiring someday and I wanted to be an online professor from home. I went back to school and able to do that. And I found that there's this healthy people stuff. And I'm like, what is it? Well, what it is, it's a government driven program that looks at different disparities and people and tries to look at what we can teach them in order to make them better. For instance, nutrition, right? Teaching about that. Look about the school lunches, right? WIC programs for food for all the kids. We know not being inside watching TV and playing games and going outside, the physical activity. oral health. All of these things are focused on children. Now, the reason why I mention this, many of you I know will go on for your higher level degrees, and you're going to have to figure out where to do papers. What sort of papers? What sort of do I do them on? Well, there's not just healthy people for kids. There's healthy people for all different things, all disparities. And I actually did a lot of my papers out of healthy people. So this is Healthy People 2030. I actually started on 2010, showing my age again. Jeez. Now, some of the problems with children, yes, it's obesity today. Years ago, we didn't have as many kids that were overweight. Number one, we didn't eat out fast food. It wasn't like that. Number two, we didn't have video games. We were lucky if we had 3 channels on the TV. So we were outside playing. We were in our bikes. We were on tires. We were climbing trees. We were doing whatever. Kids don't do that today. And because of that, they're sedentary. And now we have a bunch of children that are overweight because they're not moving. Okay. When you have overweight, you have that problem of possibility of type 2 diabetes, especially as they get older. So again, children, we need to teach, and we're going to find school age children are people we're going to be teaching. We know kids, they have injuries all the time. Highest injury place for kids and all age kids, motor vehicles, whether they're in it or run over by it or rammed into it. I've seen three toddlers ran over by cars, backed up, ran right over them. So again, these are real problems with children. Mental health. Children have serious mental health problems. I've seen young kids, schizophrenic, paranoid schizophrenia, voices in their head, and they're not spoiled, they're not rotten. They really have issues. And again, it's part of kids. Now, infants. There's 2 words here I want you to know: neonate and infants. Neonates are the first 28 days of life. Neonatal ICU, that's where they get it. It's the first 28 days of life. Up to 1 year old, now they're called an infant. That's the difference in names if you see them. They're not the same. Neonates are the itsy bitsies, okay? We know that infant death is really determinant on how much did they weigh at birth and how premature. The smallest infant I saw was a 575 gram. It's less than a pound. It was in my hand. And, the heads are about this big, the size of a walnut. They come in and they have lots of issues just because of their size, and they're so fragile at this. Death rate for children younger than 1 are going to be higher because number one, they're going to be born with all of these problems. Their immune systems are not working. And as they get older, we're going to see those death rates actually get better. But we're talking injuries when we get to be toddlers, they're going to increase. Toddlers, they want everything now. Me, mine, I do, and they're going to go get it and they don't care. And they have no filters. So again, they can jump off of couches onto cement floors, crack their heads open. And again, they don't know what they're doing. So death rates can increase. As they get older, it becomes more of bacterial stuff because they have had all of these diseases and illnesses, that have bet their immune system and really built it up well. When we talk about death rates and we talk about adolescents, we know that as adolescents, now they feel that they're little adults now, right? And they want to be able to do what they want because they're old enough now. This is the time where injuries increase, motor vehicles, okay? Homicide. They're having they have guns and things and they don't know how to use them. And sometimes it's because of gangs and the people they're with, but it could be just as simple as guns in the house and they're an adolescent now. They can touch them. And then the other thing is suicide. And why suicide? We're going to go into adolescence in week 3, but adolescents are really struggling with body images. Think about you as an adolescent. You were too fat, too many pimples, your hair was too short, too curly, too straight, all of these things. It's body image, and it's all about being accepted by others. And that, when they're not, suicide increases. So specific groups that children that have increased deaths and illnesses, of course, homeless, poverty, low birth weight. How about those chronic illnesses? It could be something like cystic fibrosis. It could be any of those things. And again, foreign born, we don't know exactly what's been going on. And look at this. Children in daycare centers have an increase in morbidity. Why would you think of that? What do kids do all day long? They play. What do they do when they play? They put toys in their mouth. And then what does the other kids do? Take it out of their mouth and put it in their mouth. So they're swapping spit all day long, swapping germs, getting each other sick, which is good and bad. So it can cause an increase in mortality and morbidity because of that germ swapping they do. So nursing and children, pediatric nursing, you're not just taking care of a kid, you're taking care of a family. It's a family-centered care. What does that mean? We know the family is the constant in the child's life. It's all they know. Think about the younger kids. They've not been out of the house. They've not seen how other people do things. They only know the way that their family has shown them, right? So that's their constant. And then I'm going to ask you, what is a family? It's whatever they say it is. It could be 2 grandparents, a daughter, and she has a child. It could be adoptive parents. It could be 2 mothers. It could be 2 fathers. It could be a group house with everybody in the family lives there. It could be anything. A family is whatever they say it is. That's who is their family. Now, the things, and it's what I did my dissertation on for my PhD. The one thing that I've noticed is children are afraid of needles. And in Miami, they say, no pinche, no pinche. That's the Hispanic of, don't pinch me, don't give me a shot, okay? So my dissertation was school-age children's attitude and behaviors towards injections. Why were they afraid, or why weren't they? Because we know children that are afraid to get injections become adults who are afraid to get injections, needle phobia, which give their children needle phobia, which will get injections, which means they're not being immunized for COVID, influenza, any of them. Again, you have to have compliance in order for, these things to work, right? So atraumatic care and giving shots. What did I do? Well, how did I minimize the stress and the pain of getting an injection? Well, I developed a program called Huggies, like the diapers, but H period, U period, G period, etc. Help us give great injections efficiently and safely. I proposed that a child that was in a parent's arms did better because they had less fear, stress, and pain before, during, and after an injection. Because once the injection's done, they're already being hugged by mommy. Huggies, all about atraumatic care. These are the things that we do for kids. We use numbing creams. We use distraction. We use everything to decrease the amount of pain. Can you imagine a chronic kid, let's say a sickle cell kid, chronically going in IV sticks? And a lot of them, they don't have any veins left, or their skin's so dark you can't see veins. They're stuck. And all I know is I'm going to go get stuck. I'm not going to tell everybody I hurt because I don't want to go because they're going to stick me. So if I came in, used numbing creams, they didn't feel any of this pain, they're not going to be afraid. They're not going to be stressed. And they're going to say, hey, I hurt, get me to the hospital. Okay. Makes sense, doesn't it? And that's pediatrics, keeping them in the program and not afraid of it because we can. There's things that we can do. You know, I think you can see nursing is all about the relationships between your children and the family. I have had many families, they're my ears and eyes to those kids. I would tell them what I'm looking for, what to look out for, when to call me, when to get me, except what to do. So I'm teaching them what to do at home, but they're also helping me when they're in the hospital. So I use my parents and doing what they want to do. They want to help their kids. So I teach them how. That's through that therapeutic relationship. And again, it's teaching them all about prevention, promotion, and et cetera, injury prevention. So again, we're all involved in every aspect of nursing here. Now, the leading cause of death among African American boys ages 15 to 19 years old is you've got boys, you've got adolescents. What do you think is going to be that leading cause?
See, firearms homicide.
It is firearms homicide. Yes, it is, Hattie. Thank you. Oh, by the way, I love your name, Hattie.
Thank you.
I knew someone in my past with your name, and I'm trying to figure out who it was when I saw your name. Okay, chapter 27, definition of a family. I told you, it is whatever they say it is, all right? And they don't have to be two guys, a boy and a girl. It could be two boys, two girls, it could be grandma, it could be an aunt, an uncle, adoptive. I mean, family is whatever. Again, there's all types of them, aren't they? Family functioning is something that we do have to look at because, for instance, the last 10 years of my career, I worked in a trauma center in an emergency room. And you had to very quickly figure out, especially, and did a lot of trauma. I was a primary trauma nurse. These uh, kids would come in with these big injuries, and I had to figure out who was the parent I needed to get information from and who I had to get patient rep in to calm down because they couldn't handle it. It's you've got to know the roles of your family, right? Because then one person at a time talk to me who knows the information, and then we could get information quick and we could take care of that child a lot easier, better, and more accurately. We know there's all sorts of parenting types, right? We have the ones that let the kids do everything and the ones that are strict, and that's just parents. It's whatever they want to be. We know that adopting a child can be a special thing, especially cross-racial and stuff today, even languages, etc. We know that divorce and kids is a big stressor. Again, when we talk about adopting kids and telling kids that they were adopted, very important. Again, and there's all sorts of parents. We got working parents, single parents, and daycares, fostering, etc. So we know that there's a lot of different things that can influence the child. And we know it's the people surrounding them, which is their environment. And the environment is schools, their peers, the community, and of course, social media. I mean, Snapchat, Instagram, whatever else is out there, I don't even know anymore. Again, they all influence children. We know the race, the ethnicity, of course, poverty. We've already talked about that and how it can affect these children. Another thing is religion and spirituality. Now, the one thing about religion and spirituality and children in the hospital, you do not have to understand their religion if it's something that's not yours. Okay. You just have to know your beliefs. And if the child and the family's beliefs are different, you need to give them the opportunity to practice their religion as long as it doesn't affect the care of the child. Okay. Sometimes it's important. It could be prayers, it could be some sort of things that they do in order to make them feel better. We don't have to understand it. We just have to give them that space and the opportunity. So, a frequent health problem of migrant children and adolescents in the United States would be what?
Tuberculosis.
Migrant.
Yeah, that was tuberculosis.
Yeah,
Tuberculosis.
migrant. Yes. It's something we don't really think of, do we? Because we've really knocked it out in this country. But if we stop, testing for it, etc., it could come back again. All right, let's look at genetics and growth and development. So, children are born, and I'll go from this. They born at, let's say a baby's born at 7 pounds at birth. By 6 months, they've doubled their birth weight. And now they're rolling completely over. At birth, they have learned how to suck, swallow, and breathe. By 6 months, they're rolling over, suck, swallowing, and breathing, and starting to move, right? By 1 year old, they've tripled their birth weight and they're up on their feet, walking or attempting. It's in 1 year. It is interrelated, simultaneous, ongoing. And if you blink your eyes, you're going to miss stuff. And that's growth and development in children. It's growth, it's development, it's maturation. It keeps going. It's learning. We know that there are stages of development and there's certain things that should be done, and we do measure them. We're going to start going into those certain concepts. Fine motor skills, gross motor skills, what are they and what do we expect when? When should they be jumping on 1 foot? When should they quadruple their weights? All of this stuff we're going to be talking about. But again, that's next week. We'll be talking about it. We know there's directional trends, how they grow tall. Again, that sequential trend. The first thing a baby does is lift their head, right? The second thing they do is turn from their bellies to their back, and their backs to their belly. And then they're up on their knees, and then they crawl, and then they get up and they creep and they walk. And that's within 1 year. That's the sequence. And that's of gross motor skills. Fine motor skills. They take their hand and in their palm, they have a reflex grasp. They put something close, they're going to grab it like they're hugging a finger, like, oh, I'm giving you a hug. Then they put a rattle next to them, they grab it by themselves. That is a voluntary grasp, all right? That is a palmar grasp. First it's reflex, and then it becomes voluntary. And then it goes into using the fingers and the pincer grasp. So again, these are certain things that they go through. Sensitive periods are those periods where they have some key learning that must be done. Now, children, when they're born, their heart rate is 140 to 160 at rest. Normal. Your adults are 60 to 100. That's normal, right? Now, I did send you a vital sign sheet in your first announcement. And the reason why I sent it for you is I want you, now you don't have to know the numbers. Just know that the numbers, heart rate comes down, blood pressure goes up. Respirations are high and they come down as they get older. And again, you need to know these numbers. For instance, what if you're giving digoxin to a child? And if their heart rate was 60, can you give it or not? Depends on the age of the child, doesn't it? Are they 16 or are they 6 months? That's the difference. And you need to know heart rates, okay? That's why I put that there. Temperature. At birth, they cannot regulate their temperature. Why do you think we have warmers and hats and we wrap them up so much when they're first born? It's because they don't regulate themselves. As they get bigger, of course they do. We know sleep and rest, kids, infants, and they sleep a lot, hopefully. Hopefully they sleep through the night, right? And again, nutrition. the single most important influence on growth. They don't eat right. They're not going to think right. They're not going to have the fine motor, gross motor skills. They're not going to be. They need good nutrition to be able to function. We know there's all sorts of kids. I mean, that's just part of it. I mean, I was very lucky. The last two grandsons I had are Mr. Mellows, both of them, two boys. Although my son was a terror. So again,
I got one of those
all
too, not mellow.
oh, no, not Mellow. By third grade, he was suspended for taking a book and hitting kids overhead and squirting fountains in the bathroom, etc. But that little boy is now retiring from Army Special Forces in about 2 weeks. So yeah, that was the rotten kid.
That's what
Again,
I
you
always
can't
think
give
with
up.
him. I'm like, these might be hard characteristics to deal with now, but when he gets to be an adult, he is a force to be reckoned with.
Just like my son. And he
Yeah.
grew up to be 6'4". Where that came from, I don't know. But again, okay. Theorists. There are several theorists you need to know. And you're going to hear me talk them over and over and over again. And I'm going to try to do it in a manner to help you. When we talk about Freud, it's anything that has to do with sex. The only one here that doesn't look like sex is latency, which is school age children. And all of that means is they hang out with same sex peers. Boys don't with girls and girls with boys usually. It's usually girls with girls and boys with boys. They hang out. That's normal for school age. That's Freud. Now, Erikson. Erikson is a theorist who talks about the child response to people around them. And I'll give you the first example. Trust versus mistrust. What does an infant need about people that are around them? They need to trust that when they cry because they're hungry, they're dirty or gassy or whatever, somebody's going to go pick them up, right? When they don't come, and this can happen, let's say you have a family that's in drug abuse or, they left the kid home alone or things happen, right? Nobody comes to pick up that kid. That kid is in mistrust. So I trust, I'm happy, healthy. I'm just a great, jolly baby. Mistrust baby, not going to be because his needs aren't met. I'm going to go through them a little bit longer, more next week. But Erikson is about the people that come in contact with children at certain ages and how they respond. Cognitive development, the way you think, is about Piaget. Let me bring you back to sensorimotor. At birth, what does a baby know? Nothing. We smack the butt, they take a breath, and they breathe. Then we take a nipple or a breast and stick it in their mouth, and we expect them to suck, swallow, and breathe. Somehow they do it. Nobody taught them, right? Sensorimotor. What does that mean? Well, remember I told you that little reflex grasp? They grasp the finger or they grasp the rattle by a reflex. Well, they do that, and it's a reflex, and then it becomes voluntary. But that rattle, all of a sudden I moved it and it made noise. Oh, I like that. So now that infants learn when I grab that rattle, if I shake it, makes noise. I like it. So you see how they've taken a reflex grasp, become a voluntary grasp, and then they shake it and put it in their mouth because everything goes into a kid's mouth. That is Piaget. It's learning how to do things in steps. So this is learning. We'll go into that. I'll go further than that. Kohlberg. Kohlberg talks about right and wrong and a consequence for each. I don't go into pre-conventional, conventional. I don't do those things. What you need to know is Kohlberg, especially when we get up to the preschoolers. Infants and toddlers don't know right or wrong yet. They're just going to do it because they're going to do it because they don't know better. Now, preschoolers now are starting to know what's right and what's wrong. And they know if they do something wrong, they're going to be punished. But if they do something right, somebody's going to say, oh, you're such a good kid. Oh, let me give you a popsicle. I mean, again, that is Kohlberg morality. Now, another thing kids do is play, right? Don't we play all day long too? Don't you all got a computer game on your phone that you play when you need time? Again, we play all the time. Kids, from the moment they wake up to the moment they go to bed, all they do is play, 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 play. And it's a lot of learning that goes on with that. So, types of play. Well, social affective, you play with a bunch of people. Sense pleasure, that's like sand, that's like goo, mud, stuff in the hands that you want to play with. And kids, mashed potatoes, after they eat and smushing it everywhere and they make this mess, it's actually a good thing for them because they're playing with it. It's part of that learning. I've got a 14-month-old grandson that I've been doing that with, and smush everywhere. And then, of course, it's bath time at night when he's done. But it's part of what they need. Skill play, building blocks or snapping them together as they get older. Unoccupied play, that means alone. Dramatic play could be in a hospital where something's happened that they didn't like, but they don't know how to express it in words, or you don't want to make them relive it. We give them toys to play it so that we can find out what happened that got them upset. And we know playing games with kids makes everything non-threatening. Okay? Especially toddlers. Where's your nose? Where's your ear? Let me tick you under there. I mean, these are things we do and they help. Sensory motor development. It's all about infants. It's all about your toddlers. It's all about sense, okay? Which is about touching in the ori in the mouth, moving it. It's like taking a car. Oh yeah, I eat it, but yeah, I don't like that. Or a block and in the mouth, all right? And then fly in the air. Now I'm an airplane, and I'm take the block and I put it on the floor. And now it's a car rolling around. This is sensory motor. Again, children explore everything in their mouths. It's all about the touch, the mouth, and the movement. This does help with their intellect. It helps, out playing with other kids, being creative. It's all what they need to do. Toys and making sure that they're appropriate. Now there's types of play, and you need to know these, okay? We know onlooker, that's easy. That means you're watching someone. Solitary, you're alone. Now the next three, you need to know the differences. Parallel play is parallel to each other kids are playing, and they're not sharing. This is toddlers. They don't share. Me, mine, mine, don't touch my toys. Toddlers playing here, one's over here, no sharing, parallel play. Then they become preschoolers, and they become associative play, which means there's a bunch of toys on the ground and they all play with it, and they all share and they all play and they all play and they all share. That's associative play. Cooperative play, kids playing all together again, but there is a goal, whether it be in racing, making a race car set, making a sandcastle, something happens. There's a goal. It could be playing a board game, a checkers. I won checkers. I won an old maid, whatever. Cooperative play. They're all play together, but there's a goal. Somebody wins. Why do we like play? Well, again, it does help with their child's development. It also, when they're playing, many times it's parents with their children. And it's that time where they can sit and giggle and cuddle up with each other and, learn each other well. We know that play, it's that pushing, pulling, rolling, using those muscles. I mean, my little grandson, he's 14 months old. He doesn't crawl, but you should see this kid with one leg sticking and sort of trying to move all over the house. He's up on his feet. He's almost walking, but he's running in his walkers. He's always up on his feet. He follows the house all the way around that he can touch something. And he'll go around the whole living room, a whole kitchen, back into my bedroom, a whole living room. And this kid all day long, all day long, all day long. And that's playing. What is he doing? He is making his muscles work. He is playing. He's being creative. He's learning. And that's what play does. Developmental assessments. For instance, why would you want to know if a kid was not sitting up at 8 months old unsupported? Because every kid, textbook, should be sitting by themselves unsupported. What if you have a child who's 12 months old who can't sit up by themselves? There's a problem. It needs investigation. This could be also with the grasp. This could be rolling. This could be all of those things. These are why we look all these developmental steps. Are they there or not? And if not, we're going to find out why. And then early intervention. Now, I was doing clinicals at a prescribed pediatric daycare. And I'm telling you, I was so impressed. It's a place where they had infants, toddlers, preschoolers area, and they had like what we call the high level area. Those are your CP kids that have G tubes, maybe a trach, all of those things back there. And this place really focused on early intervention. They had physical therapy there, problem with walking, turning, crawling, physical therapy. Then they had occupational therapy, same thing, manipulation, using your hands. And then speech therapy. Speech not only works with talking, it also works with showing them how to figure out colors and shapes and those things. So speech works on swallowing. What about the Downs kid with the big tongue? They teach him how to keep the tongue in. That's the first thing I noticed. The kids' tongues weren't sticking out. They worked so hard with those children. So again, early intervention. That's what we do. We know genetics. We know kids can be born with things. We think of Downs, right? That's the one thing we think of. We think of a congenital abnormality. But all different things can happen. Some things we can predict, some things we can't. But again, what is our role? Our role is going to be there to support. And if we find that a child's having some sort of genetic thing that went on, of course, we will have them get sort of genetic testing in case they want more kids, right? So communicating and physical assessment. The one thing don't forget is that there's HIPAA, even with kids. The one thing with kids that could be frustrating is, let's say you have an 18-year-old kid, boy or girl, don't matter, comes into the ER with mom or dad or whoever, and they get their treatment. An 18-year-old who's cognitively aware has to sign for their own care, which means you cannot give mom, dad, grandma, aunt, uncle, anybody any information unless you get it approved through that child. You've got to be careful. That's a HIPAA problem. Communicating with families. As I said, number one, find out who's the person who knows the information. I am from Miami. In an ER, you get one kid come in, sometimes with Hispanic families, you might have 10 people show up, and all of them want to talk at once. And I'm like, okay, I know you're all here. You all love your baby boy, Billy, or whatever he is. I said, but who knows what's going on? And let them talk first. And then we can let you talk. Again, it's how I approached it, because I'm telling you, there'll be 10 there. And of course, abuela, grandma, really wants you to know what she's talking about, you know? So find out who's the person and let them talk. But bring them back. I don't need an 8-year-old kid's history from birth if there was no problem at birth. I want to know, why are you here this time? Okay, that's directing the focus. Another thing, listening with cultural awareness. What does that mean? Well, I have found out I lived in a very narrowed type of population in New York until I was 24 and I moved down here. And I didn't understand a lot about cultures, but there are some cultures that you can't look in their eyes. It is a sign of you're not respecting them. Also, touch. I'm a toucher. I'm a hugger. I couldn't. You can't touch. You've got to keep the space there. That's what I mean by cultural awareness. Know what that family is about and don't try to impede yours opinions or your way of doing things on them, okay? Another thing is being empathetic. I know that I've gotten many, many young babies into the ER on a Saturday morning because I worked every weekend. And that mother, is exhausted. The kid's been sick since Monday. She has been to the doctor on Tuesday. She went back to the doctor on Thursday. The kid's still sick. She's in the ER. She's been working. She's got 3 other kids at home. You know what I'm going to say? I'm going to say, wow, you've done a great job. I said, we're going to take care of your baby. Tell me what you've been doing. And when you sit there and you let them know that you understand what they've gone through, being tired, sick kid, don't know what to do, you're frustrated. That's all they want to know, that their opinions, they've been validated. They know that, hey, she understood. That's awesome. Another thing is when we have a patient that doesn't speak your language, you can't have a family member translate for you because they're going to put their own opinion on it. And you don't want their opinion. You want the opinion of the person who told you. So you should get those blue phones, or if there's an interpreter there, you can. I know I moved to Miami and there was Spanish everywhere. I spoke none, so I had to learn it quick. But up to that point, I had to find my interpreter. Communicating with kids. How do you do that? Well, the only way to speak to kids is you've got to get on their developmental level. I would always have stickers or things in my pockets for my kids. That always used to help, especially those ones that are really they're scared. Oh, I got a Spider-Man sticker. Come on, let's go in the room and let's see what we could do here. And then of course I'm going to play with them. So children, young kids, infancy, preschoolers, let them sit on mommy's lap. Let them have that comfort place and get on their level. Another thing, don't stand above them. Get down. They feel like you are looking down and you're threatening. I'm not a little girl. If I stood above them, they would be frightened. I would always sit on a chair actually below them, and then I would start playing with them. I'm giving them a sticker, et cetera, et cetera. So on their level, sit down below them, and that's where you can start the communication and use play. Again, the history taken, again, you've got to find that informant. We've talked about that, and find out, why are they here this time? When you're doing the history, I want to know a brief birth history. Were they admitted, or they went home, or do they have issues or not? Anything with their diet, their nutrition, their milk, lactose intolerant, they couldn't breastfeed, or they're on this special formula. I need to know those stuff. Any previous injuries, operations, of course, allergies, any medications, acetaminophen, ibuprofen, I need to know it. And I think probably the biggest one that I need to know, are their immunizations up to date? If I get a young infant less than age 1 coming in, no immunizations, upper respiratory, fever of 101, I'm scared, because it could be things like pertussis, which is extremely dangerous for many people. So again, immunizations, and that actually helps you with placement of your patients. And of course, growth and development. Are they where they should be or they think? And what about habits? This is the only binky, the only pacifier this kid will use. If they're admitted to a hospital, you need to know that in case the kid's screaming, you know what pacifier or what doll or what blanket or what does a kid like? Do they bite their nails? What do they do when they're upset? These are things you need to know. Older kids coming in, sometimes we need to know things like sexual histories. For instance, you get a young adolescent girl in who's you've seen before, and this is their second urinary tract infection, and you saw them 6 months ago, and you're like, parents left the room to go get some coffee. So you're like, so why are you always getting urinary tract infections? Are you sexually active? And I would ask, I don't need the parents there to ask. Okay. And most children wouldn't, especially girls, they're not going to tell me in front of parents, most of them, because they don't want them to know. So if we need to know information like that, parents out of the room, we can ask them these questions because I can say, well, if you're having urinary tract infections and you're sexually active, maybe one thing you could do is immediately after having sex, you urinate. That be an information, that be probably part of it. And then another one is about giving birth control to adolescents. Can we? Well, we can give them oral and written information. That's it, not our opinions, okay? One of the things that I can tell how a kid is doing is by asking them about school. What's your favorite teacher? What's your favorite subject? What was your grades on your report card? These things tell me little things. Do I have to teach them slower, or do they catch on quick? These can help me. Another thing is doing assessments. We don't do head to toe assessments on children. We do focused assessments and get the rest in. If they come in and they're not breathing well, they're tachypnea or whatever, we're going to listen to the lungs first, right? And then we'll get the rest of the stuff in when we can. One of the ways we can do really good lungs and cardiac sounds on the smaller infants is when they're asleep in mommy's arms. That's when you do heart and breath sounds. I need to know how they're eating. What if they're vegetarian and I see a low hemoglobin hematocrit? I want to get the dietitian in there to make sure that they're getting the proper stuff. Also know if they're lactose intolerant, are they getting enough calcium in their diet? These things are important. Physical assessment, as I said, it's no head to toe. It ain't happening. That's for adults. And again, when you're doing the assessment, again, you need to minimize the amount of stress that you are going to put that child through. Again, put them in mommy's arms, sit down below them, start to play games with them. Where's your nose? Is your heart here? Put the stethoscope there. I mean, make it fun for that child. And now they're going to cooperate and you'll be able to get a really good assessment on that child. And that as you're doing these assessments, and if we're doing anything to a child, always let them know what's happening. Kids, remember, if you tell them something's not going to hurt, or you don't say anything about hurting and this thing hurts, they're not going to trust you ever again. So always make sure developmentally appropriate on their level, explaining things so that children can understand what's happening. So, which approach would be best to use to ensure a positive response from a toddler?
A.
You want to get on their eye level? Yes, we do. Thank you. So these are all the things that we do. Every single visit on pediatric children, not adults, children, we do a height and a weight. Do you know why? We're measuring development on these children. If they're not gaining weight and height the way they should, cognitively, they're not going to be there also. So could it be a growth hormone? Could it be a thyroid hormone? Could it be nutrition? What's going on if this kid's not gaining enough weight and enough height? This is one thing that we do all the time, and we catch stuff like that. On children, we do apical pulses because we can hear it better than trying to do a radial or a brachial pulse. Know that there's all sorts of blood pressure cuffs on these kids. They have some that fit on my little pinky, and they do work. When we do kids, first thing is we look at them, and it's a general appearance. We can have a well-appearing or a sick-appearing kid. What would a sick-appearing kid look like? They'd be sitting in the corner, not moving. A well kid be running around screaming and having a good old time because that's what kids do, right? So, general appearance. What's the color of their skin? Is it dry? Is it pink? These things. We're going to be looking at accessory muscles. Are they having retractions like that bottom picture there? That's really deep retractions going on. Lymph nodes in their necks. Are they swollen? Lymph nodes should only be swollen when they're sick. If they're healthy, not sick, there should be no lymph nodes showing at all. Okay? We're going to be looking at everything when we assess their ears, their nose, their throat, their chest, their lungs, their abdomen, their heart. The abdomen, the first thing we always do is we just look. Is it rounded? Is it distended? Is it loopy? Infants get their intestines. You can see their loops in them when things are going on. Genitalia. Sometimes there's ambiguous genitalia. We're going to go in that in week 6, actually. Also, there's fused labia. There's all different things. So we need to check these things. We need to make sure there's an anus. There's something called an imperforated anus. And that means that there is none, which means we need to have an escape route for the GI tract really soon. So again, that'd be a surgical emergency. We're going to look at the back, making sure it's all closed. We're going to be looking at all of their neurological. New babies, do they have that startle, that moral reflex? They hear a noise or you hit their crib and they got hands up and their feet up. We'd be looking for those things. On infants, when we're doing our initial assessment, we always do a head, a chest, and an abdominal circumference. Their head circumference is done to make sure that they don't get hydrocephalus, swelling in the brain, okay? Because we do it every first assessment, and if we see an increase, we're going to tell the doctor because this could be swelling that's going on there. The chest we do at birth. We usually don't do it later on. But the thing is, the head at birth is bigger than the chest because it has to get the chest through the birth canal. By 1 year old, 15 months, they should be the same or the chest should be bigger. Okay, that was one question that I saw off of a HESI. Abdominal circumference. Why do you measure how big their abdomen is? Well, we're feeding them. Is the formula, is the breast milk, is it being absorbed? Is it coming through? If a child's having a problem with feeding, the abdominal circumference would go up. So it'd be something we would watch. Checking a height on a toddler. Little preschoolers can be really hard. They see this big piece of wood coming down on their head and they think it's going to hurt them and bop their head, right? So what do? I play. I get on, that thing to do my height and I put it down and I put the thing and I tap and I go tap, tap. Oh, I feel it there. And then there's a little number to the side. I said, look, I'm a number 7. What number are you going to be? So come here, put yourself here. Okay, do your tap, tap. Is it on your head yet? Okay, what's your number? Now I have just I've got an appropriate height. I've got a kid who's not upset. And my number. That's all I need. Blood pressure cuffs. Now, we usually do blood pressures on the upper arm, right? On children, I actually do most on their lower leg. It's less threatening. The one time that you have to do with all 4 extremities would be a cardiac child. But you can do a blood pressure on any limb. You could do it upper, lower, doesn't matter. I do that lower, number D, because I could be there with their leg and I could be playing with the kid up here and the kid's not going to be upset. And I think this is probably my thing that I've always focused and worried about with kids is pain assessment and pain management. I have seen such an evolution of betterness, let's want for another word, in the treatment of pain in kids. At first, we didn't think kids had pain or they wouldn't remember pain, but we found out that kids do have pain and actually there is some sort of memory there. So, children, still even with all of this, many of them are still suffering from inadequately treated pain. Why? Well, it could be due to the kid's not going to tell you they're in pain because they don't want that needle or they don't want that liquid, or daddy told them, no, you shouldn't have pain, so you don't tell anybody. Could be any of those. Or it could be due to the nurse is not doing a pain assessment. It has been since the early 2000s by the Joint Commission that we do a pain scale every shift, right? What is your pain? Zero's no pain, 10's the worst pain in the world. What's your number? And if it's above 4, you need to show the intervention. There's all sorts of pain scales we use on kids, and it's the same thing. It's not just identifying the pain, it's not just giving that medicine, it's going back and saying, did it work? Do you need more? Do you need repositioning? Do you need an ice pack? Do you need a warm pack? What do you need? Okay, that's how you effectively treat pain. Sometimes it's we're not giving the proper dose, we're waiting too long in between, and again, it's always that evaluation. Now, Black scale. Black scale is used for infants up to the age of 3 and nonverbal. Children, adults, don't matter. Black. And what it does, it looks at the facial expression. Are they crying or are they smiling and happy? Their leg movement. Are they calm or are they kicking because they hurt so bad? Their activity, laying straight in bed because I don't want to move because I'm going to hurt. Crying, and can you console them? That's the Flax scale, and that's for infants up to the age of 3. At age 3, and you could use this forever and ever if you wanted to, it is the Faces scale or Wong's Facer. It's from 0 to 10, and there's pictures on there. I'm telling you, 3-year-old kids will point to pictures. And the neat thing about kids, they don't lie. Ask an adult how much pain they're in. They're in a 20, right? A kid will look at it and they'll be a 6. And you're like, okay, he really hurts, because a 6 is quite a bit of pain. So Flax scale is for 0 to 3 nonverbal. Faces is from 3, can be used forever on if you want. And yes, we do have that numeric, which they say at the book starts at age 8. So that is the scale. Nonverbal children are probably older kids. I've seen 16, 18-year-old CP kids, nonverbal. And we do use that infant scale, that Flax scale, and it does work. We know there's all sorts of pain. Chronic pain could be rheumatoid arthritis, which I have. Recurrent pain, sickle cell, could be persistent, could be, an appendectomy, you need an appendix going on. So pain is always there. We know long-term pain can really affect you emotionally, physically, socially, every different way. So addressing pain and maintaining good pain control is what we need, especially for some of these children. There are some checklists that are out there, and I just put this up there to show you. Every hospital has their own forms and their things. Some are very similar, some are a little different, but there are different types of forms that you might see. A non-communicating children's pain list, just to let you know that those are types of ones they do have. In pain management, it's not just giving that medicine, that painkiller. No, it's so much more. In children, I think the biggest thing is distraction. Give a kid in pain their pain medicine, give a 10-year-old an iPad, let them play games, they're going to forget about it. Or take a young kid, and start putting music on and dancing, and they're thinking you're fun too. Distraction, playing a game, giving them crayons, play a card game. I mean, all these things, any sort of distraction can be done, and it stops that focusing there. We know infants love to be swaddled tight up in the blankets, but after they get older, no, they don't. The biggest thing used in young children for pain control is a pacifier or a non-nutritive sucking device. We know children soothe themselves through their mouths. There was a study done by Harvard. It was neurophysiologist something on infants, males, being circumcised. And they looked at morphine and a pacifier, two groups. There was no difference in pain control with the morphine or the pacifier with a little bit of sugar water on it. So we can use just a pacifier with sugar water on it. One of my grandsons had it with a pacifier, and he cried because he didn't like to be strapped down for the circumcision. But once he was let up, he didn't care because he was sucking his pacifier. Pretty good. We know it's not just giving morphine and all those strong medicines. There's acetaminophen, there's ibuprofen, and then we've got those special things, those PCA pumps. Older kids can use those. We could push the pump when we're in pain, and we could program lockouts on it. We use a lot of that little white dab of cream on that little girl's anticube area, this EMWA, or a numbing cream. And what that does is they can get blood taken, stick a needle in, you're going to feel touch, but you don't feel any pain. So we use it a lot. That girl's not upset. She's going to get blood drawn because it's already numb. She already knows that. We know that kids who don't get treated for pain are not going to be happy kids. Where is pain in kids? It can be anywhere. Could be teething in the infants, right? Could be that circumcision that my grandson had. Could be surgery. Could be all different things. So, which of the following is an important factor for consideration in understanding the pain experience in children?
B.
They're not going to admit. And why? They don't. It could be the father telling them they shouldn't have pain, so be quiet. Or it could be they don't want that liquid, they don't like the taste, or they don't want the needle, right? So let's go ahead and let's do our first cahoots. Anybody want to win the Kahoot today? All right, Victoria, I'll let you win. Okay. Hold on, I'll get it. Do you see the Kahoot screen or you see one?
It's the screen before you click on like learn.
Can you see it moving now?
Yeah, it's loading.
Thank you. Thank you. Appreciate the help. So you either go to kahoot.it and you put in the code, or take your cameras and do the code, and it will bring you right to the game. You will be getting this game so that you can play by yourself or play with, one of your classmates. And again, it goes over concepts you need to know. There's 33, and then we're going to be done for tonight. It looks like my grandson, Mia. Was he about 9?
He's about as tall as a 9-year-old now, though. He's about to be 7 this year.
7? He's a big boy.
Yeah.
All right. Kahoot! The leading cause of death from unintentional injuries in children is so motor vehicle accidents. Remember, infants are not putting it right, they're going to have an accident. Toddlers, preschoolers especially, getting run over by cars. And then as we get to be adolescents, now we're driving them. Now you're really scary. Which statement is most descriptive of pediatric family-centered care? What does that mean?
Hey, I can't read the whole question because your like box with your screen on it is like in the middle of the two answers.
My box, you mean?
Like the picture of you.
You should be able to minimize that.
Oh, let me see. Oh, dang. My bad.
You. So families, no, this is how we all learn. It's not a problem. Family-centered care. Remember, the family is the only constant in that child's life. It's all they know until they're older, okay? That is their constant. And remember, a family is whoever they say it is. The major cause of death for children older than age 1 is. And it's unintentional injuries. I mean, children older than 1, what happens is they have no filters. They're doing things they don't know that they can be hurt. And that's what the unintentional injuries is. The nursing care for the child in pain understands that distraction. Remember, distraction, no matter how you do it, must be developmentally appropriate. And I'll give you an example. Let's say you have an infant crying. I'm not going to give them a sticker and give it to them. Say, here, you like this, play with this. They're not going to know this. That the distraction is not developmentally appropriate. You wouldn't give an adolescent a sticker. Again, developmentally appropriate. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? They're playing together with no goal. Which one is that? And that's preschoolers. It's called associative. I know it's the first time you're seeing it, but I'm going to tell you, I'm going to warn you, you're going to see it again and again. Statement best describes the process of critical thinking. Critical thinking. Do you remember when you did your orientation in nursing, they talked about you're going to learn how to think critically? You do it every day. You figured out what you had for dinner, right? That's critical thinking. You figured out how to get the Zoom to get to me. That's critical thinking. We do this every single day. It's purposeful. It's goal directed. Simple. What is probably the single most important influence on growth at all stages of development? Single most important influence on growth. Nutrition, nutrition, nutrition. If you don't have nutrition, you have no gas in the tank, you're not going to go anywhere. It ain't going to happen. You're not going to grow. Each function of play is a major component of play at all ages. What does play do for that child? It's called sensory motor activity, okay? It promotes them to use their senses, their smell, their touch, their hearing, whatever. And then, of course, their mouth, which explores the world. And of course, we know a block of this. They're always floating in the air. They're always and making things move. That motor, okay? Sensor motor. How do you apply nystatin to an infant with thrush? I throw some of next week's stuff in here just to start thinking there's differences between adults and children. They're not little adults. Nystatin is used for that white stuff on the tongue, that thrush that they get, right? And it is an infection. It needs to be treated. Now, nystatin on an adult, you swish and swallow or swish and spit, whatever they want, right? An infant don't know how to do that. So you just take a cotton swab, dip it in the medicine, and wipe it on the tongue. That's all you do. Differences, adults, children. 3 children are playing a board game is an example of what type of play? So, board game, that means somebody's going to win. That's cooperative play. That's school age children and higher, older. The head to tail direction of growth is referred to as. What's another word for a head? Cephalic is another word for a head, right? Cephalocaudal, which means direction of growth. First thing I do is I move my head. I lift my head, my neck, right? And then caudal means I'm up on my feet, I'm walking. So it starts with moving my head up till I'm standing on my feet and walking. Cephalocaudal direction. What is the single most important factor to consider when communicating with children? You need to go into that 3-year-old child's room and you need to draw some blood on them. What are you going to do? So again, anytime you want to go next to a child, the first thing you got to remember is their developmental level. Get down to them on their developmental level and then use play and you'll get anything you want done. If you don't do it, they're going to be afraid of you. What 2-year-old child pain assessment tool should the NURs use? We've talked about FLAC, faces, and numeric. Those are the 3 you need to know. So up to age 3 is FLAC or nonverbal children. I put this question in here specifically because you need to know the ages of FLAC and faces. There's a difference. FLAC means you're looking at them and they're telling you by their movement and crying. We can know what's going on. Faces, the kid's old enough to point to a picture and telling you what they heard. At 6 months, an infant's birth weight should do what? If I'm born at 7 pounds, by 6 months, and I've grown 1 inch every month for the first 6 months. You do a lot of growing that first year. At 6 months, the birth weight should double. By 1 year, it should triple. And by 2.5, it quadruples. Did you hear what I just said? It doubles at 6 months, triples at 1 year old. Then it waits till another 1.5 years, till 2.5 to quadruple. It's that first year that they really grow quickly. So you see how nutrition is so important. The first expected fine motor developmental milestone for an infant begins. Fine motor means F fingers. Lifting the head and rolling over is gross motor. Get up and go, go, go. Gross motor skills. There's 2 types, and you need to know the differences. So you need to look at the names. Fine motor, fingers, hands, and then gross motor is get up and movement, go, go, go. The first thing they do is a reflex palmar grasp. For instance, I've seen it so many times. Parents, little moms come in to the newborn ICU and their baby is in a warmer and they go up and they put their hand next to their baby and that baby grasps their hand, reflex palmar grasp. And the mom goes, "Oh my goodness, he's hugging my hand. Wasn't that sweet?" Do not tell him it was a reflex. Let her think that that baby really hugged them because it's a nice thing to think. I have never told them that it was a reflex because it made them feel good. Their baby's in ICU and he hugged them. That 8-month-old infant should be expected to perform which fine motor skills? So with the fingers, we started with a reflex and then we went to voluntary and then we went into pincer grasp. That first a smush and then it goes into, ooh, take a little at a time. That's the first year. And that's all about F fingers, fine motor. So what should they do about 8 months? They should get the grasp and they should move it and they should take that pincer grasp, but it's like they don't know one at a time. They sort of smoosh it in their face. Like they'll take a bunch of those little air puff things that they get and smush it instead of just one at a time. That's crude. That's the difference. Natural physical developmental sequence that most children follow. Physical, gross motor. What do they do? What's the sequence? What do they do first? What did I tell you? So the first thing they do is they lift their head. And then they roll from their belly to their back to their belly. Then they get up on their knees, they crawl, usually backwards first. Then they get up after they crawl, they climb up on the side of a couch, a coffee table, and they creep, they hold on, as my grandson is holding on all around the house. I mean, he's creeping like crazy and walking in between, though he's still afraid. And then they walk. And that is the normal sequence. Now, It doesn't mean they have to do everything. For instance, my 14-month-old has never crawled. He sort of like pulls himself on the floor. He gets up on his knees, but the kid is like running on his walker and doing all this other stuff, which is crazy. So you can't just take one piece that they're not doing. You've got to look, they're moving at forward. That's what, because many kids will jump spaces like he did. Which behavior indicates that an infant has developed object permanence? I didn't describe this. This is babies, children, where they see a toy and you hide it from them. Once you show a kid a toy or something that they want to play with, they're not going to forget it's there. So even though it's still hidden, they're going to actively search for it because they know it's there. Like put the stuff in the toy bin at the end of the night, right? The kid wakes up first thing in the morning. The kid knows to go back to the toy bin. He knows his car's still there or his stuffed toy's there or whatever. This is object permanence. Why they call it that? But they don't forget. In general, an infant should triple their birth weight at what months of age? At 12 months. Double at 6 months, triple at 12 months. Very good. Perform a head to toe assessment on a toddler. Most important to consider before beginning that examination. I think toddlers are our most skittish of all. And I think they're the sweetest of all. But boy, are they stubborn and headstrong, right? Again, preparing on the child's developmental level. Get below them on their developmental level. And toddlers use play because they enjoy play. According to Piaget, toddlers are in the blank developmental stage. Remember, Piaget is all about thinking, figuring out how things work. As in, I had a reflex palmar grasp, and then, oh, I could do it myself. Voluntary palmar grasp. It's called sensorimotor. Remember, we use our sense, our mouth, and movement, and this is how we explore and figure things out. That's Piaget. Which intervention helps a hospitalized toddler feel a sense of control? Now, toddlers are ages 1 to 3. They do not like change. They don't like being somewhere else besides their own place and their own things. How do you think that this kid's going to feel the best being away from their home? If we can, number one, parents stay at the bedside will always be the first thing, but also following the same routines and schedules and foods, etc. And I'll tell you the big one, bath time. If that kid is used to waking up in the morning and taking a bath, you need to continue that because they don't understand it when you switch it. If you do it every night before they go to bed, then that's when you should do it. Do the same routine. Feeding same types of food if you can, if the diet allows it, depending on what the child's in there for. Toddlers, they're hard to work with, but they're also a lot of fun. Do all children reach developmental milestones at the same age? Absolutely not. You know, we have some kids that are walking by 7 months, and all of my kids walked at 15 months. And I think this last one, I think he's finally going to let go probably in about 2 more weeks because they all are different. It doesn't mean they're smarter or anything. It just means they took more time. They're all different, unique. And that's why I love to work pediatrics. They're not the same. You can't write the same story twice with kids. Mm-mm. Immunizations for a 4-month-old infant. What action should the nurse take to provide adramatic care for this infant? 4 months. And they get at 2, 4, and 6 months, like 4 different immunizations. It's a lot. And I'm sorry, immunizations hurt. So how are you going to stop that hurt? Give them a pacifier. As simple as that. Don't overthink it. Don't go too hard. It's just a pacifier. That's what really does help them. Which of the following immunizations is administered to a newborn? You don't know this one yet, but I'm putting it out for you. DTaP, polio is 2, 4, 6 months. MMR is at 12 months. And Hep B is at birth. It is the first one. You don't need to know all the immunizations, but what I just said, those are the ones: hepatitis, MMR, DTaP, polio. Just sort of knowing generally where they are. The normal heart rate for a neonate is 140 to 160. Neonate, first 28 days of life. By the age of 1, it's probably 100 to 120. That's how quickly it goes down. Which is a preferred site to give an injection to an infant? You're giving immunizations. Where are you going to do it? And it's called the vastus lataris. It's the upper outer thigh. And when you give immunizations, pedal the legs to get the medicine in. And if it becomes warm, put a nice cool pack on it. Sometimes a heat pack, depending on the child, when we're giving those immunizations. And know that it is not uncommon that children get a little fever with these immunizations. The body is building those antibodies. So giving acetaminophen is not uncommon. The death of an infant under 1 year old with no known causes.
Hey,
And that's
Shariah,
kids.
whoever's in your screen, you can like see what they're doing on their phone. Thank you.
The Vietnamese mother of a child avoids eye contact with the nurse. Considering cultural differences, why? Remember, I tell you, cultural is going to be a big thing. Where, what do you do? How do you act? And I'm going to tell you, if you don't know, ask the parent, ask that older child, and they will respect you. I've earned a lot of respect because I don't know, tell me. I don't know. I'm clueless. And I'm telling you, just like you want to teach them, they want to teach you. So it's actually very good. So again, eye contact with the Vietnamese could be all about respect. All right. And if they're not looking at you, say, why aren't you looking at me? I'm not going to bite, right? I could say something like that. And she would say, it's just what we do. I like learning about culture. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why is he saying that? So again, this is a cultural belief of, this gentleman, maybe it's Mexicans, it could be the group or not, but again, ask him why he says it. Which term refers to times in individual life where he or she is more susceptible to positive or negative influences? And that was called I can't go back here. It's the sensitive ages. What is characteristic of the pre-operational stage of cognitive development? Again, this is Piaget. Again, I'm just introducing it. We're going to talk more about it next week when we do our newborns and infants and toddlers and preschoolers. So when we're talking about understanding, this is cognitive development and understanding. When you are young, which is the pre-operational stage, you've got to see it before you can replicate it. So it's concrete. Concrete means I can see it, touch it, feel it, smell it. If I can see it, touch it, smell it, I can do it again. I can now think that, I can replicate that because it's concrete. I can see it, touch it, smell it. That's what that means. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What did I tell you about Kohlberg? What is he all about? So again, morality is all about right and wrong and a consequence for each. Toddlers and infants do not have morality. They don't know it yet. But preschoolers now understand right and wrong. So how did we do today? Number 3, Katie, good job. Number 2, Mackenzie, whoop, 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 whoop. Drum roll, number 1, ding, ding, ding. Amelia, good job. And Avi and Erica, okie doke. So this is all I have for tonight. I will be posting all of this for everybody, okay? So that you will be getting it in Sarah's class, my class. You'll be getting the Kahoot. You'll be getting the PowerPoint. I'm going to send it all to you. So you'll be getting it all in about an hour or so once it does download and gets ready. Anybody have any questions about anything? It's been an absolute pleasure. If you need anything, contact me. Tell me before, don't tell me after, and I'm here to help you. And let's make this a great term together. Okay? Bye, guys.
Thank you.
My pleasure.
Bye, everybody. It was nice to meet you.